Hi, everyone. Welcome to the cholesterol webinar, Cholesterol Decoded, What Your Numbers Really Mean. I'm Dr. Dominique Vanier. I'm a naturopathic doctor, and I practice in Burlington and see patients Ontario-wide virtually. And today we're talking about a practical, evidence-informed guide to understanding your lipid panels and how they can be used to assess cardiovascular risk. So, we're going to spend the next 30 minutes discussing cholesterol. I'm going to let you know really everything I know about cholesterol. And at the end, hopefully, you'll feel equipped to know more about your numbers and what you can do to improve them and really understand the key factors that influence your lipid and your metabolic health. A little bit about me. I primarily see patients who are experiencing metabolic challenges, digestive issues, and hormone issues. And surprisingly, all three can overlap, and it's not uncommon to see all three presenting in one particular patient. And my goal is really to help people take control of their health and take back control of their health. I'm also a conference speaker and educator, so I've educated over 1,000 healthcare practitioners across Canada. I'm really excited for the next point. I have a podcast launching with two of my colleagues in the late spring called the Gut Girls Podcast, and we're talking all about digestive health. The first series is on bloating. There's many different causes of bloating, and I completed my Doctor of Naturopathic Medicine at the Canadian College of Naturopathic Medicine in Toronto. I did my Master's of Science at U of T, and I did my degree in chemistry at Queen's. And my most proud accomplishment is being a mother of two young kids, a mama of two and under. Drinking lots of coffee over here these days. And just real quick about, my process and my love for helping patients. I like to investigate, identify, and implement. And so my process when I work with people looks at the deeper drivers of cholesterol, including hormone balance, metabolic health, and digestion, as we'll see the crossover in the next few slides. But I have used this process with thousands of patients to really identify the drivers of cholesterol and implement strategies that support long-term cardiovascular health, because it's not just about decreasing somebody's numbers, it's really about the prevention and the health optimization aspect. I'm excited about this initiative. So this is the last slide before we dive more specifically into cholesterol. I think in the era of AI and access to information, it's nice to have kind of this grassroots, ground up community medicine type of approach where people feel like they can have authentic interactions. So I am doing actually monthly free webinars on a variety of topics. The next few you can see here, the next one's on digestion, followed by perimenopause. And certainly, if you feel like you have a topic that you would like me to dive into, I'm more than happy to explore that. So just send me an email or reach out to me. Okay, just an FYI, this is not medical advice. Everything in this webinar is information and for educational purposes only. And if you have questions, you can pop them in the chat and I'll answer them at the end of this webinar. Cholesterol, I would say, is one of the most misunderstood markers. Some people panic over numbers that aren't really a problem. Others, they feel safe when there could actually be an issue. The bigger picture, so hormones, metabolism, digestion, tells you what truly matters and what to do next. And a lot of the things we read on social media, we do really want to take with a grain of salt. A lot of studies can get misinterpreted. The data can be misinterpreted. There can be, extrapolations that aren't like practical or what we actually see in patients. So, it's important to learn how to interpret your results and to understand how you can reduce your personal individualized risk of a cardiovascular event and cardiovascular disease. I wanted to quickly go over what cholesterol actually is, because maybe we're so used to seeing it like on our lab panel, but not actually knowing necessarily what it is or how, the role that it plays in the body. We do need cholesterol. It is not a villain, but we don't want too much of it. So it's primarily made in the liver. The liver produces about 80% of the cholesterol in your body. And it synthesizes this cholesterol from dietary fats. So, like the dietary substrates, including fats, the sugars, proteins, like everything you eat can be made into cholesterol. The intestines also produce cholesterol, and the liver and the gallbladder work together to excrete cholesterol. The gallbladder rather, will release cholesterol in the form of bile, and then that goes into the small intestine and it helps digest your food. And this is also where, in the presence of fiber, fiber can help excrete bile from the cholesterol and bile from the body. Cardiovascular disease in Canada. So, cardiovascular disease remains one of the leading causes of death in Canada. Cardiovascular disease refers to conditions affecting not just the heart, but also the vasculature. So, this includes blood vessels. And the most common form of cardiovascular disease is atherosclerotic cardiovascular disease, which occurs when we have plaque that builds up inside the arteries. This plaque will narrow arteries and it can reduce blood flow to vital organs, and we then can see an increased risk of major clinical outcomes like heart attack, stroke, and peripheral artery disease. And so the role of cholesterol in cardiovascular disease actually has a lot to do with what we call cholesterol years. Cholesterol disease develops over decades, and exposure to elevated lipoproteins is one of the major drivers of risk. So the longer somebody has had high cholesterol, the more, we'll say, like potential damage has been done, which can increase the risk of things that we don't want. Um, Now, cholesterol itself travels in the blood within something called lipoprotein particles, such as low density lipoprotein. And ApoB containing particles can enter the artery wall and initiate plaque formation. So ApoB refers to like different levels of low density lipoproteins. The higher the concentration of these particles over time, the greater the likelihood of plaque development. And so this is why the Canadian Cardiovascular Society guidelines focus on those specific markers. It has to do with these low density particles that can lead to plaque and then impact the vasculature wall. You do want to think about your cholesterol numbers more as a primary indicator rather than a lagging indicator. So if we have cholesterol that's starting to creep up, it's a clue. It's a clue that we need to do something now. Most of the time, it's not a response to something else, which would be like a lagging indicator. So here's a standard lipid panel. This one is how Life Labs reports it. I particularly like how Life Labs reports it because it does have, as you can see, like a bit of explanation underneath some of these lipid markers. But the lipid panel is typically done fasting. The average is 12 hours. So somebody would usually go before breakfast, and you will see the patient's reported numbers in this column here, so on the left side. And if anything is flagged, you see that it gets flagged here and bolded. And then the reference range is typically reported on the right. So we obviously want to make sure that somebody is within the reference range, but then also want to see where on the reference range they are and possibly how far outside the reference range they are. So triglycerides and cholesterol are different types of lipids or fats in your blood. Um, Cholesterol itself refers to total cholesterol. And as you can see here, this person's total cholesterol was flagged just above the reference range at 5.97. HDL refers to high density lipoprotein. This is known traditionally as, quote, good cholesterol because it carries cholesterol from other parts of the body back to the liver. The liver removes it, and then that lowers heart disease and stroke risk. HDL primarily acts as like a scavenger. So it's going to scavenge or absorb bad, quote, bad, or LDL cholesterol in the blood. So non-HDL cholesterol, that refers to the total cholesterol minus your good HDL cholesterol. So your non-HDL cholesterol actually represents all the, quote, bad cholesterol that you have in the blood. And the bad lipoproteins are both your LDL, your very low density lipoprotein. So LDL, VLDL, and IDL. Oops, let's go back here. I got went backwards just for a sec. And then the last marker that is reviewed here is something called the cholesterol to HDL ratio. That's more of a measure of heart disease risk by calculating the total cholesterol by somebody's good cholesterol. And an ID rate ratio is going to be about 3.5. So this person has a ratio of about 2.8. But I will say, like, sometimes this can actually underestimate somebody's true risk, and you'll find out why in just a moment. So the lipid panel gives us a really good idea about what's going on, but we also want to look a little bit further, and you'll see how we do that in just a moment. And this is where the Framingham risk score comes into play. So this one, you can actually Google this. There's many different ways that, or sorry, different websites that have the Framingham risk score on it, and you can input your own personal numbers. But the Framingham risk score is used to estimate an individual's 10-year risk of a cardiovascular event, such as a heart attack or a stroke. And you may have actually done this in your family doctor's office. It's quite common that family doctors, when they get somebody's lipid panel back, they will calculate this with the patient to let them know this is your 10-year risk. And it's a tool that lets you know, whether you're low, intermediate, or high risk. And so I've just quantified that on the left side here, that low is under 10% risk, intermediate is 10 to 19.9, and high is above 20%. And it does include things beyond cholesterol. So it includes somebody's age, their sex, whether they're a smoker, their systolic, which is the top number of their blood pressure, and whether they're on blood pressure medication. And there's an algorithm for when a medication is recommended. So one of them is when, if somebody is a high risk individual, so they do this calculation and they get that their risk is above or equal to 20%, they are automatically recommended statin medication. And statin medications include things like atorvastatin, rosuvastatin. That's the main drug class for cholesterol, and that helps lower cholesterol and LDL. And statin therapy on its own is recommended regardless of what anything says on the lipid panel. If somebody comes back with an LDL-C above 5, it's typically an automatic prescription. Now, there's something called LPA, or lipoprotein A, and this is where it uses the same calculator but adds in this LPA marker. And it's actually a more accurate risk score because the LPA is a marker or reflection of somebody's genetic risk for a cardiovascular event or cardiovascular disease. And so LPA, it's typically done once in a lifetime. It's a measurement that is now recommended for initial lipid screening to assess risk, and that's per the 2021 Canadian Cardiovascular Society guidelines for the management of dyslipidemia. Sadly, this test is not in the scope of naturopathic doctors. I requisition lipid panels pretty much every day with my patients, but I'm not able to do the LPA. So I'm often writing letters to family doctors or even to the patient's cardiologist requesting that they do run the LPA. Perhaps somebody has a strong family history of people who've had heart attacks or strokes. And to see what that person's more genetic risk is, which can help them make a decision about whether they need to be starting medication right now, or maybe they have a little bit of time to work on their diet and lifestyle. So LPA is a genetically determined type of, we call it bad cholesterol, like I mentioned, that acts as an inherited risk factor. And a high number of people in the population have it. About 20% of the population has elevated LPA levels. High levels indicate an increased risk for heart attack, stroke, and aortic valve disease due to this increased plaque buildup, inflammation, and clot formation. And we usually just run it once because LPA levels typically don't change over somebody's life. And so this is where questions around like the decision to medicate come from, because there are many factors as the Framingham risk score tool. There are other important things that go into deciding when somebody needs to take medication. There are various factors or areas that lead to a prescription regardless of somebody's Framingham risk score, and that is if they have clinical atherosclerosis, if they have or have have or have had abdominal aortic aneurysm, if they have diabetes mellitus, so that's type 2 diabetes, they have chronic kidney disease, or like I mentioned, if their LDL comes back above or equal to 5. And you can just take a look at this section here. This is more like the algorithm. Depending on somebody's Framingham risk score, if they're in the low, intermediate, or high risk, statins and the target for their LDL will change. And then sometimes additional tests are done, which help make the decision on whether somebody should be starting a medication. So if somebody has an elevated C-reactive protein or CRP, which is a marker of systemic inflammation, certainly if they have an elevated LPA above 100, if they have completed a coronary artery calcium score, which this determines the amount of calcified plaque in the heart's arteries. So if that comes back above 0, and then if they have a strong family history of premature cardiovascular disease, all of those go into the decision on whether to medicate. And then here, just below this is based on Canadian algorithm LDL targets. So you can take a read through that. I will say lower cholesterol equals lowered risk. And that is true. Despite what you read, on Twitter or on TikTok, we do want to have normal cholesterol levels. That's an important goal. Decreased cholesterol reduces cardiovascular events by one, preventing plaque progression, but two, making it more difficult for that plaque to move, essentially. So this picture shows a plaque, but if we can stabilize it, then we can also reduce the risk of it moving and then occluding an artery somewhere else in the body. And this is an interesting point that you may or may not know. So HDL, known as the good cholesterol, there's a reference range, so it's between 1.3 to 2 in Canadian numbers. And HDL, higher levels of HDL do not always correlate with better cardiovascular protection. So what the research is showing now is there seems to be a U-shaped association between HDL and all-cause mortality, all-cause cardiovascular mortality, and non-cardiovascular mortality. What that means is that, if we're hanging out here, so we have low HDL, that is not protective or not as protective as it could be if it was in the normal range. But even if it's above 2, we're starting to recognize that this also may not be protective. We don't want it to be too high. And I think this now, so going forward, now we can start seeing an overlap with other systems. And so your practitioner needs to really investigate if your cholesterol fits into a bigger picture of your health. Certainly, diet and lifestyle habits make a very meaningful, impactful role in somebody's cholesterol, but that's not always the case. I have met many, many patients where they are eating very nutritiously dense, high protein, like high vegetable intake, normal calorie intake, and they are exercising like 4 times a week, and their cholesterol is still high. And this is where we can start seeing that there are other factors that may be driving somebody's cholesterol. One of them is perimenopause. Starting around early 40s, we can see like fluctuations in estrogen, particularly those drops in estrogen, drive higher cholesterol numbers. And so for some women that I've spoken to, they may have had normal blood sugar and cholesterol levels their whole life. And then all of a sudden in the mid 40s, we start to see those numbers change. We can see this metabolic like a cluster. So insulin resistance, type 2 diabetes, high blood pressure, non-alcoholic fatty liver disease type of picture. And then we typically will see also cholesterol play a role in that metabolic profile. Polycystic ovarian syndrome, we're more likely to see high cholesterol in PCOS, chronic kidney disease, liver disease, hypothyroidism. There's an association with higher levels of cholesterol. Some autoimmune conditions like inflammatory bowel disease, we may see higher cholesterol levels. Certainly, if there's a strong genetic pull, family history of either high cholesterol or even cardiovascular events. And there's also an association with low vitamin D levels. So, it's important to investigate, like, is this high cholesterol just really part of diet and lifestyle habits, or is there something more going on here? And now we're talking about the treatment side of things. And so this is all based on research. It's not specific to you. It's not medical advice. It's more like what the research is saying. But certainly diet can go a long way. And so a well-balanced diet is considered to be the most effective approach and may reduce LDL by more than 10%, which is a meaningful shift. This likely includes reducing saturated fat intake and increasing consumption of foods that we know have cholesterol lowering effects. And that primarily refers to fiber. And so there's the note about saturated fat, and that refers to a lot of fatty meats, but also like heavier dairy. There's some plant sources, including coconut oil, palm oil. A lot of baked goods will have saturated fat. Some people have challenges where saturated fat drives their cholesterol numbers, and some people it's a little less impactful. And I'll go back to this point in just a moment because there's a separate slide on that. But I do want to mention fiber. So psyllium husk seems to be the most extensively researched fiber supplement for cholesterol reduction, which is followed by oat beta glucan. Now, anybody who sees me in practice knows how much I love psyllium. And that's because there's a lot of really great research on it. For cholesterol, it crosses over a lot of digestive issues. It can result in a meaningful change in LDL numbers. So we can see in the research a 5 to 13% reduction. And as well, the Mediterranean diet has some great research behind it too, and that has been shown to reduce LDL, total cholesterol, and triglycerides through multiple synergistic mechanisms. And that really refers to like it's able to essentially like remodel parts of the microbiome. The microbiome and the digestion do play a role in somebody's cholesterol numbers. And so there's this PREDIMED trial, which is a large trial that demonstrated a 30% reduction in major cardiovascular events with the Mediterranean diet. And what's important here is like when we look at somebody's risk of having the, CV disease, an event, versus just their numbers dropping, like we really do care more about somebody not having a heart attack, right? Like numbers are just numbers on a piece of paper, but what's most meaningful is like that they don't have a heart attack or that they don't get the disease. Those are the most clinically important things. And fiber, I've had many questions actually in my patient appointments on whether fiber timing matters. It it may not. There's been no direct comparison studies that have been done, no head-to-head research trials that compare like a single bolus dose once a day high dose of fiber versus divided doses. Although it seems like most research looks at it more divided, but I will say it's tricky to do divided doses just from like human habits. Anytime we have to do something 2 or 3 times a day, we're much less likely to do it. So, the goals being for a woman, at least 25 grams of fiber a day, for a man, at least 38 grams. And I, usually say if we can get fiber divided into all of our meals, then that's a win. And one important thing to note is that when we have fiber and the presence of fat, we will see the gallbladder contract bile. Within that's cholesterol. And in the presence of fiber, the fiber will bind to the cholesterol and then excrete some of it. And so that's the mechanism and how fiber works and why it's important. And saturated fat. So I wanted to spend a little bit more about this. And I use the example of myself and my husband. We eat the same diet. We're pretty much the same age. All the background types of influencers are pretty much the same. Normal blood pressure, all the other things, non-smoking. We exercise about the same. So we have a lot of the same factors, but uh, he seems to be a hyperabsorber of cholesterol, and that seems to be his genetic blueprint, whereas my cholesterol numbers are always significantly lower. And so it's interesting, right, where we can see saturated fat may affect some people much more than others. And that has to do with what seems to be like this a hyperabsorber type of picture. These individuals known as hyperabsorbers do seem to have a genetic predisposition to absorb more cholesterol from their diet compared to the average person. And the trait is genetically determined and can affect how their bodies process dietary cholesterol and saturated fat. And there seems to be a link to ApoE4 carriers. They tend to have higher total total and LDL cholesterol, and show a greater lipid response to dietary fat challenges. And certainly lifestyle, like as it relates to levels of exercise, really important for cholesterol. But what does that actually mean? Um, that refers to a combination of aerobic and resistance training. That seems to produce the most comprehensive lipid improvements across all parameters. The Canadian Physical Activity Guidelines do recommend at least 150 minutes per week of moderate to vigorous aerobic activity. And so walking is considered more to be low intensity. When I'm talking to patients, I'm often, referring to like some level of resistance training plus high intensity. And some of the research says like you want to be at around 40 to 55% of aerobic capacity. And what that means is you're able to have a conversation with somebody, but you feel a little bit breathless, but not too out of breath where you can't have a conversation. It's like that level of exertion that we want to be aiming for. And then just lastly, in the support section here for cholesterol, there are some supplements that absolutely do have research for decreasing cholesterol and for LDL. However, what we don't know, what the research has not really studied, is whether taking a supplement will actually reduce somebody's risk of a cardiovascular event and cardiovascular disease. We know that some supplements can decrease total cholesterol and LDL, but the way statins have been studied, which is like I mentioned, the main drug, statins have been studied to decrease that risk. We can extrapolate the data from supplements, but we don't 100% know for sure. And of course, there are many supplements that may help but may not, right? Like some people respond differently to things on this slide here. Some people have side effects, especially, berberine is one of the ones that can cause a bit more GI distress compared to others. It really depends on your physiology, and how you implement it. And that's really where your naturopathic doctor can help. Um, and really just kind of understanding your health and your plan as it relates to your cholesterol and metabolic health. I suspect a lot of you watching this already know a lot of this information. And you're probably here because you've already tried to lower your cholesterol. And so that's where I find actually, AI or ChatGPT or whatever platform you're using can be helpful. The challenge is that it's, AI is still not very good at medical nuance. I'd say it's really poor. Medical nuance is best understood and implemented and interpreted by practitioners. But also, like working with a practitioner looks at your unique physiology, discusses a strategy for implementation, how things are spaced out. When do we know that we need to pivot? How long does it take to see changes in your blood work? And then when do we repeat your blood work? But really, what's important is a strategy for habit changes, because truly, as it relates to diet and lifestyle changes, those are about changing somebody's habits. So you probably know you need to, whatever it is, exercise more regularly, consistently, etc. That's where somebody like a coach helps you. And so that comes to the end of the presentation. So certainly if you're in Ontario and you're looking for a naturopathic doctor, I am, more than happy to help. You can book a discovery call with me or even your first metabolic health appointment. You can listen to the Gut Girls podcast that's coming out soon. And I'm also doing free monthly webinars on a variety of topics. And if you have an idea, please reach out. I hope you found this webinar helpful and I hope we get to see you again soon. Okay, take care.